I've got a few props with me, which I'll come back to later. I'll just start my timer here as well. Okay, well, good morning. Thank you very much for allowing us to have this session here today. I founded Community Gateway about 3 or 4 years ago, quite a tough time, just before leaving the Department of Health on a programme called TSIS, which I don't know, have many of you heard of Transforming Community Equipment Services, which was the retail model? Just a quick show of hands if you have. Okay, so a few. It sort of can be a contentious project, but really the main point about it was to try and normalise the experience. So I wanted to start just by a very quick empathy exercise, and I want you to imagine, in terms of Telecare, Telehealth, Assistive Technology, that this is the experience that you go through when you're buying your next mobile phone. And I've got a picture of the next mobile phone, by the way, that you'll have at the end of this process. So the first thing is that we get a referral. We need to speak to the right person to get the referral. So it might be a doctor, or it could be a social worker with a care assessment. And then from that point, we find out whether we can have something or can't have something, but we don't know what it is at that specific point in time. So we might see a picture, so it might be, well, we've got one of these, we've got an iPhone, so you can have one of those. But you've got to wait for the assessment, so it might take, say, 6 to 12 months for the assessment to take place. Not only that, if you want to see the phone, we've got a couple of places where you can see the device in action. It's an independent living centre. Has everyone heard of an independent living centre? Yep. So you can go to the independent living centre or a demo flat. And the hours are a couple of hours on a Monday morning, Wednesday afternoon sometimes, and maybe on a Friday. I know it's not the case everywhere, but ring ahead, just in case we're, because the hours can be a little bit funny. And then at the end of that, if it's not something that's, what you were looking for, I don't know, let's have a look. Are you happy with the phone that you've got? No? Well, that's all we've got really, because by the way, the other thing is that it's second-hand as well. It's been used before, but don't worry, it's clean. And that is the experience for most people that receive assistive technology that's loaned to them. It'll be second-hand, and it's very difficult to find where you can purchase them from if you just want to go and buy it. So even today, I've got some example products of a project that we did earlier this year. I'll tell you about that in a second, where even these products, there's a pill dispenser, which is fantastic, and just checking system, GPS mobile phone, GPS watch. They're probably all in this hall, but you could spend 2 days looking for them on the different stands. And that is not that different to the experience for people looking at from the high street. So assistive technology, just to frame the definition really, is it could be, and this is for the King's Fund and the Social Care Institute for Excellence, it could be something like a high-tech device, Remap, which is a charity that will take a device. If there's nothing that exists, they'll remodel it. They took a Sony e-reader apart for somebody, rewired it with a cable that was a wire that was the width of a hair, and they turned it into a home automation device. It was a Sony e-reader. It could be an elastic band. Carry an elastic band around with you. If somebody suffered a stroke and they can't grip the door handle to open doors, that's an assistive piece of technology. It could be absolutely anything. And that's sort of really, what we're saying here is any product or device that can help somebody live independently. So we've got 2 short presentations. One is about a project that I did earlier this year, which was to try and normalise the experience, to see what the feedback would be if you change the environment and the way it's presented. And the second presentation is from a colleague, Vinny, that's a fellow for the Centre for Welfare Reform, that's about a trip to India that Vinny made, and some very interesting innovation that's to do with assistive technology and mainstreaming. So if you want to speak to Vinny, myself, or my colleagues after as well, there's a stand just outside the doors on M78. So the first thing, what I was going to say was, we did a project for a city council, and we looked at what we were asked to do was build a business case to present information online to people. Lots of local authorities, lots of organisations, NHS is looking at promoting information through websites, which makes a lot of sense. And lots of people do have access to the internet. But the target group, when we looked at we matched the Joint Strategic Needs Assessment, PopUp data, with the digital inclusion survey that the local authority do. And what we found was that the older population, which is not really a big surprise, 4 out of 10 people aged 65 and over had access to the internet, so there was a large proportion that didn't. But the other thing that was more alarming really was that compared to 90% of the population of people that don't have any long-term condition or disability, only 60% of people have access to the internet. So you're missing a large proportion. So our sort of premise was that it's really got to be about how you engage people socially and how you spread these messages. Some of the challenges in assistive technology, the barriers if you like, are, let's start with leaks and the drop-off. There's a Netherlands study carried out in 2011 that showed that there was a 75% drop-off in assistive technology that was due to lack of support after the equipment had been provided. So information, guidance, and you can see it if you come and see us on the stand. Some of the packaging doesn't include, really important informational instructions, guidance. So once people have got the equipment, they then don't know what to do with it, so they don't use it. And you might have had similar experiences with other consumer type electronics as well. The other challenge is that the products can be very stigmatized. My thinking on this is that it's not just the product that's stigmatized. So I mean, like here, we've got a uresis sensor, which is a standalone uresis sensor, but of course you can have sensors that are linked into personal home alarms, Telecare and Telehealth. But changing the environment and the way that this is presented and the experience can completely alter the way that somebody views that product. So there's some of the challenges. Now, in February this year, I saw an opportunity to take part in a competition. It was a retail competition, and it could have been anything. It could have been retailing cupcakes, sunglasses, phone covers, anything that you wanted. And what I wanted to do was experiment with Telecare in a shopping mall, because it appeared that had not really been tried before. Somebody said, well, we've got a shop that's in a hospital. I said, yeah, there's Costas now in some hospitals, but I mean, it's quite unusual, isn't it, really, to find a Costas or WH Smith's in a hospital. So it really needs to be in a shopping mall. So I spoke to an old school friend of mine, Ben Smolden, who's a quadriplegic. He had quite a severe spinal cord injury when he was 17 in a collapsed scrummage, and asked Ben what he thought. And a lot of what I'm saying to you, I know it's quite hard, to accept sometimes, because we're trying hard to improve some of those experiences. But for Ben, he avoids it as far as possible because he finds it humiliating. It becomes almost like a sort of second-class citizen because the experience is so different to access basically just enabling products. So this was the pop-up shop that we created. We traded for 2 weeks, and we had, you can see there's on the end there's the uresis sensor, there's the pivotal pill dispenser, there's care alarms, pendants, there's magic plugs that, for people that forget and leave the bath running and it leaks. Seeing the products in that context, people weren't it didn't come across as stigmatized. And the dialogue that we started with, because we met lots of families and people that were looking after other people as well, and we'd start off talking about, for example, a GPS device, a personal GPS device. So, well, do you know anybody that goes running in the park? Like this was in Sutton Coldfield, which has got one of the largest parks in Europe. So, do you know anybody that goes running in the park on their own? Or have you got children that travel home on their own? Do you know anybody that's starting to get a little bit forgetful? We didn't mention any labels at all around dementia or disability, but we moved on to that topic. So as the dialogue started to open up, it was a lot easier. And there was one example that I wanted to share really, which was there was a woman that was with her daughter that was probably of, like, say, university or college age, so not quite independent, financially independent, but more so. But still dependent on the parents to a degree, and an elderly father, and they were just passing by through the shopping mall, and her parting comment, because the gentleman appeared to be, sort of maybe a bit confused and disorientated, was it was wonderful that she could see things just in a normal shopping environment, because to go and say, Dad, I think you need to have a care assessment, or you need to see your doctor about, your memory, it's a really hard conversation to have with families, and it just sort of breaks that sort of ice. So that's it. You can sort of see in the background, it's a Clinton's card shop in the background. There was Costa's opposite. The Apple shop was just a little bit further down the mall. It was all voluntarily supported. There was Stonham Mental Health Services, Carers UK, Age Concern, that all supported it. So we provided information as well with the service. So we talked about Carers Emergency Response Service. There was one chap that was looking after 3 or 4 people. And it was very social. Like the 2 people here, this is Dawn, that was one of the volunteers. We had a lot of fun with it. You know, the gentleman here was a rambler, and he had friends that were starting to get possibly early onset of Alzheimer's, or certainly confused and losing things and forgetting. And we asked, you know, we started off talking about, like, with rambling GPS devices, and, you know, if you've got grandchildren that, you know, walking home from school and things like that, and then on to, you know, being confused or Alzheimer's dementia. He said, you know, are there people that you can think of, you know, in your associations that would find this useful? His reply was, there's not a single rambler that's never been lost, ever. So, you know, so it was mainstreaming the products where it wasn't just for a particular set or group in society, and treating, you know, everybody more sort of equally, really. So in terms of different models of delivery, the top left-hand picture is an Apple shop. I've talked to a couple of local authorities about the independent living centres. You know, the independent living centres where you go along and you can see products out on display. For the sort of cost that I know some authorities have spent on refurbishing or finding, you know, better locations, and I have colleagues that work for Sony, anyway, not Apple, but Sony. The sort of standard of fixtures and the experience, and, you know, touch screens to see things like the Home Farm Trust Virtual Smart House. You could have that type of experience as part of an RC, but often it's a bit more sort of, you know, like the one I've been to recently. You sign in at certain hours. You're greeted by, and there's nothing wrong with this, but greeted by either social workers or occupational therapists. Now, in an Apple shop, you're not greeted by geniuses. I don't know how many of you have been into an Apple shop, but they have these geniuses that will talk to you about all these, you know, fantastic things that you can do with an iPad or a smartphone or whatever. But the people that greet you first are more sort of general customer-facing people, and then you can book an appointment with a genius. The other model is concessions. Why not put independent? This is a Google Chrome Chromebook store in a PC World shop. Why not put an ILC into a John Lewis or into a Waitrose or Tesco's, where people are going already? You know, probably be cheaper accommodation-wise, space-wise. The bottom left here is Geek Squad, and Geek Squad is quite big in America, but it's just a different model, different way of maybe delivering sort of the support service. Can talk more about that. That might seem a bit vague at the moment. The top left here, that's Tesco's actually in South Korea. And what people do in South Korea is they take their phone and they scan. They go up to these posters that are in the subway. They scan a QR code. It drops into their shopping basket on their phone, and then they book the delivery. So when they get back in the evening, they've had their delivery for their grocery shopping. Now, I'm not saying that's exactly how, you know, Assistive Technology, Telecare, Telehealth could work, but what you could do is you could have these sort of posters in pharmacies. You could have them in GP surgeries, where it's sort of, you know, raising the awareness of what, you know, these devices can do for people. The bottom left here is an Avon party, and what I liked about this was Staffordshire County Council. They do something called Box of Tricks. There's a question called Jim Ellen that started it, and what they do is they take these boxes of tricks out, which has Telecare, Assistive Technology and Telehealth, and they share it around people, and they get to touch and feel and play. It's the community liaison officer that does that. But what you could do is you could set up a box of tricks idea with the products, very social. People could take them home, have, you know, they could take them to community centres, clubs, associations, and share them out, pass them round, and it's very, very social. You know, it's sort of it's easy to break down those sort of boundaries. Now, what I've been saying really is nothing new in what I've been saying. I'm not asking you to believe me. I know there's like with whole systems demonstrator, there's lots of debate about whether, you know, whether are there actually benefits of doing it. Lots of things would never have happened if we'd have waited for the evidence first. Got some brilliant quotes around, like one of the presidents of the United States of America said, you know, rail travel will never take off because it will set fields on fire and women and children will be crying with fear. And that was about, you know, travelling at 15 miles an hour on a train, you know, because the evidence wasn't there. And there's loads and loads of quotes like that. And now you might say, well, here's a politician, but there's lots of other quotes from clinicians, doctors. The Queen Victoria surgeon said no one will be ever to be able to operate on the heart or the brain. It just won't happen. So what Sony did was they experimented in like parks. They got people to wear, while they're rollerblading and skateboarding, wore a personal stereo, and it just sort of normalised it, because the barrier with the personal stereo, and look at it now, look at the iPod now, was people said it will never take off because the headphones look ridiculous. So on that note, I'm going to hand over to my colleague Vinesh, that's going to talk about a charity bike ride that he did and some very interesting technology innovation in India with contact inocular lenses. Thanks. Sorry.
Thanks, Richard. My name is Vinesh. I'm representing the Centre for Welfare Reform. I'm a fellow of Centre for Welfare Reform, which was founded by Dr. Simon Duffy, the guy who promoted or invented the concept of personalization, self-directed support, and resource allocation, and so on and so forth, personal budgets. And the centre is actually a place where there are 70 international fellows, and it's a network of people. It's independent, no paid costs or anything like that, and it's for people who wanted to share ideas, thoughts with others, to promote citizenship, to strengthen families, communities, and to increase social justice in the world. So that's the hat that I'm wearing today. I was a health and social care provider before becoming a consultant for personalization and integration for local authorities. My day job is a commissioning manager for integration of health and social care in a London local authority. So this bike ride changed my life. The guy who's standing next to me is a surgeon at Walsall Manor. He's my brother-in-law. And I only did 500 miles and it changed my life. He did 2,500 miles from Jammu and Kashmir to Cape Comorin, which is the southernmost part of India, in 2011. And I joined him because his friends gave up at the last minute. They were going to join him and they said they couldn't. So I joined him from Bangalore, south of India, which is Silicon Valley of India, to Cape Comorin, where the 3 seas meet, which is Bay of Bengal, Bay of Bengal, Indian Ocean, and Arabian Sea. Anyway, this trip was life-changing, and as you can see, we had the shoulder. We made the good use of the shoulder that we had, and that's what we were doing every day. So it was 7 days. And what changed was this. It was for a charity, and then we ended up sponsoring some cataract operations in a place called Aravind Eye Care. So every person and anyone who does MBA in Harvard would know that Aravind Eye Care is their case study. Usually case studies last for 3 to 4 years, and that's their lifespan. But Aravind Eye Care has been there for 17 years and still growing strong. And the reason for this is this. This guy you see in this picture, this person, was an ophthalmologist. He retired at the age of 58 in 1976, and he wanted a post-retirement plan. So he founded Aravind Eye Care with 11 beds in a remote part of Tamil Nadu in southern India. No money, no business plan, no safety nets. Only thing was, he wanted to see all as one, to give sight for all. And it was simple. I think we need to look east, or we need to look at lower and middle income countries for any transformation of NHS or social care or anything in this country, because what we are following is not sustainable. I'll come to that. But what this guy did has now grown into something phenomenal, absolutely phenomenal. And so the principle that they had was, it's an unconventional model that came into being not because, but because of the deep-seated compassion at the core. The model demonstrates the power of innovation with empathy, business principles with service, outer transformation with inner change. And that's exactly what's happened. We got, I think, 39 million people in the world with blindness, and I think 80% needlessly so. And so in India, cataract is a needless blindness, and accounts for around 60% of blindness in India. So in 38 years since the launch, I think in 1976, with a team of 3,200 people now, with 21 ophthalmologists, Aravind has performed, I think they do 300,000 surgeries a year. An average surgeon in the United States performs 200 surgeries, eye surgeries a year. And in Aravind, it is 2,000 a year for one person, one ophthalmologist. So what is that? That is unique. And so let's move on. Yeah, that is it. So that you can see that for, so when I went into this place, it's a dilapidated cinema hall where you had camps, and these camps happen every 2 weeks. I think, and there are 600 towns where you have camps. And so Aravind performs, as you can see, 50% of the entire NHS is ophthalmic surgical volume. So 13.8 million pounds. Compare that with 1.6 billion pounds in United Kingdom. That is for half the number of people. And that's one, it's a group of 5 hospitals. And that's the iCam that we've been, and it's a dilapidated cinema hall used for people who come down there. And in 1999, a joint study between Aravind and London School of Hygiene and Tropical Medicine found out, because Aravind were thinking, yeah, we're doing these iCams, we're going everywhere to all these villages and in all the other places, and we must be doing very good. They were looking at the numerator, they were not looking at the denominator, and they found out that their reach was only 7%. Of the total prevalence. So they organized 40 camps a week spread across 600 towns. So in 2004, as they were looking at it, and 2001, 2000, technology was booming and all that, a guy called Sanesh Surana, a lanky PhD student from University of California, he was part of this technology and infrastructure for emerging regions, TIER something, and he came down to Aravind. And he said, and they were looking at it, and they were looking to see how they could actually change it, in the sense, make it Wi-Fi, wireless fidelity. And they then started erecting towers on top of schools and in various villages. And you had, I think, the Wi-Fi connection was probably 100 meters or 100 meters, whatever. And then they then, in 2 years' time, they then developed it to an extent that it was going across 40 miles, and now there are vision centers. There are vision centers in South India where people go, and there is a relationship here. Lord Hal Ridley, ophthalmologist from London, United Kingdom, and what he did was, during World War II, I think he was looking at people, I think casualties from the Royal Air Force, and he found that these acrylic plastic substances from the cockpit canopies, which was going into the pilots, were not causing any irritation or was not, unlike glass pieces. So he developed intraocular lenses, and that intraocular lens has revolutionized cataract operations across the world, and that's what's happened is, and now Aravind have their own manufacturing facility called Oro Lab, which manufactures. They wanted to manufacture 150 intraocular lenses a day. They went about manufacturing 7,000 a day, and they're reaching more than 10 million people a year. And they're a charitable organization, and 90% of operational costs is covered. So they went, the last to finish with, they went to see people in the villages to see how much they would afford to buy, how to spend. And they were told, look, I earn $1 a day, If it's for 10 days, then I can spend $11. And so it was $11 that the cost of intraocular lens were. Anyway, coming back here, health and social care integration, having implemented integrated case management teams for local authorities, I can tell you that when risk stratification happens, you have top 1% of people, or top 2%, 3%, and from the analysis that I've done for social care and for health, and the discussions I've had with a county council in Southeast, I can tell you that most people who would benefit from technology, most people would benefit, but people who would benefit from technology would be in the top 5 to 20% risk. And so if, as an offer, technology is embedded within it, there's a lot of things that we could do. And I think that's the point I would like to make in terms of integrated case management or anything to do with integration. That's it.
Thank you very much. We've got about 3 or 4 minutes for some questions or comments. Anybody out there? We've got a bright light, so I can't really see you. Any questions? They have a stand. If you can tell me where the stand is. M78 is where their stand is. But these lights are awful. Anybody got any points or? It seems. No, oh, there's one there. Catherine, over there. Lady in the horizontal stripes.
Yeah, I'm Sarah Lane, Chief Operating Officer from eStaff CCG. I just wanted to go back to the figures where you said 50% of the entire NHS workload on 1% of the budgets that they were utilising out there. What can we learn from that? I mean, if they can do sort of 50% of what we would be doing with the equivalent of a 1% budget, what's the biggest thing that we can learn, that we can take back?
I think they were learning from the users, the villages that they were serving. So they didn't have any fancy models of bureaucracy like we have as here. Whatever adds value to the users, service users, or the population in the villages, they were doing that. And they wanted to curb needless blindness, and they were using a lot of, for example, the telehealth aspect. They had nurses, and nurses were looking at, they were remotely sending it to the hospital consultants. The nurses were looking at any abnormalities, the cataracts. So they were using, I wouldn't say less qualified, but people who were trained to do those aspects. And the consultants in the hospitals, where these 5 hospitals were based, they were actually looking at it paperless completely to telemedicine. And now they have 5,000 people, whereas in that particular village where there was 1,000 people going every year, now they have 5,000 people going every year, 800 of them seen, 250 recommended for cataract operations. They were keeping it very simple. And that I mean, I don't know how else to say that. They were keeping it very simple.
Thanks very much. In fact, as the Russians also did this, there's a lot of downtime when theatres are being run, and we just don't use it efficiently enough. Anyway, we are running out of time as ever. Thank you, Vinesh. So could you